So starting us off today, we have Dr. Sanjay Divakaran. Sanjay is a member of our cardiovascular division. He is also the clinical director of the cardiovascular division and associate chief. He is an assistant professor of medicine at Harvard Medical School and specializes in cardiac imaging and sarcoidosis, cardiac sarcoidosis. But he'll be giving us a talk today about can't miss EKGs and what you can learn from the EKG. So Sanjay, please take it away. Looking forward to hearing your talk today.
Thanks so much, Chris, and thanks everybody for joining this morning. Excited to be here. So I have no disclosures. So we're going to go through 15 cases together. They all involve obviously an ECG, and then we'll have an audience response here to work through the cases together. And I will put a plug in for the evaluations. I find the comments incredibly informative to make hopefully the talk better every year. So case one is a 67-year-old woman with a history of coronary disease who had bypass surgery, who presents after the development of acute chest pressure and lightheadedness. On presentation to the emergency room, her heart rate is 50 beats per minute, and her blood pressure is 84 with 57 millimeters of mercury. Her extremities are cool. An ECG is obtained. What is the most important finding? One, an anterior non-ST elevation MI. Two, an anterior ST elevation MI. Three, an inferior ST elevation MI. Or four, an inferior posterior ST elevation MI. So after reading the question and the choices, I'll put up the ECG. And we'll see if our response system is good here. Perfect. So I can see kind of a live feed of you guys are answering. And so once I see the answers slow down, we'll go through it. Good. So a pretty good mix here. So the correct answer here is four, an inferior posterior ST elevation MI. And so what does the ECG show first in terms of rhythm? Well, this is atrial fibrillation with a slow ventricular response. And the key finding here is that there's an acute inferior posterior infarction, as discussed. So what you see, of course, are ST elevations in the inferior leads. But the question gets to the tricky answer choice here is that is there a non-ST elevation MI anteriorly? But what these depressions in these septal leads actually are actually posterior elevations. So the key part of this ECG is that when you see these deep ST depressions in the septal leads, in the anterior leads, you want to make sure you don't miss looking for inferior elevations because these ST depressions in the septal leads can actually be indicative of a posterior MI. So this patient is having a ST elevation inferior posterior MI. And in fact, this patient actually had an acute occlusion of the SVG graft to the PDA and underwent intervention emergently. All right, case two. A 60-year-old female presents with nausea, epigastric discomfort, and chest pressure that started about 45 minutes ago. An ECG is obtained. Administering which of the following medications should be avoided in the emergency room? One, aspirin. Two, heparin. Three, morphine. Or four, nitroglycerin. And here's the tracing. All right. So a spread of answers here, but a majority did get this answer right. And the correct answer choice is four, nitroglycerin. Okay, so why is that the answer, right? So one thing that some of you may have picked up on first off is that these were actually right-sided leads labeled with an R across the precordial leads. So instead of going across this way, across the chest, right-sided leads will go across the other direction toward the right side of the chest. So this patient's rhythm is sinus rhythm with Mobitz type 1 or Wenckebach AV block. And what we're looking at here is an acute inferior MI. But the right answer choice here is nitroglycerin because there's concern for right ventricular involvement. We'll go through some of the criteria in prior research that's indicated that you might have right ventricular involvement. But the key here is that you're dealing with an inferior MI. And in a patient with an inferior MI and certain characteristics, you want to not give something like nitroglycerin, which could reduce preload. Patients with RV involvement of an acute infarct are very preload dependent. And so giving nitroglycerin can actually cause hypotension. And so, what are some of those criteria? So these are data from Peter Zimmerbaum at the BI, in which they studied 69 consecutive patients who presented to the Beth Israel Deaconess Medical Center for an inferior wall acute MI. And what's interesting is for 55% of these patients, lead three, the ST elevations in lead three were higher than the ST elevations for lead two. And 10 of those patients met echo criteria for RV acute MI as well. And interestingly, all of those patients who had echocardiographic signs of RV involvement all had ST elevations that were higher in lead three than lead two. So the teaching points here are look for an inferior MI and recognize that. And particularly when you see that lead three, the ST segments are higher than lead two, think about RV involvement and avoid preload reducing agents like nitroglycerin. Case three, a 71-year-old man with a history of hypertension, dyslipidemia, and former tobacco use presents the ED with 2 weeks of chest pressure associated with exertion. He has never had these symptoms before. He currently has no chest pressure. An ECG is obtained. His exam is unremarkable, and his high sensitive troponin is less than 6 nanograms per deciliter. After evaluation, a decision is made to perform a coronary angiography. Which of the following would you expect to see? 1. Non-obstructive CAD. 2. Proximal RCA stenosis. 3. Proximal LAD stenosis. Or 4. Proximal left circumflex stenosis. Here's the ECG. Great. All right. So the correct answer choice here is 3, proximal LAD stenosis. And so often described and sometimes seen as what we call Wellen syndrome. And what Wellen syndrome is these deep T-wave inversions in leads V2 and V3. And these are this finding in someone who has angina, either stable or unstable, is associated with a proximal LAD stenosis. So I'm attending in our stress lab today. And when we see this in someone with a good story, we worry about this patient having significant proximal LAD stenosis. Case 4, an 82-year-old woman with hypertension, diabetes, and known left bundle branch block is brought into the emergency room by her daughter due to shortness of breath at rest. An ECG is obtained. Which myocardial territory is abnormal on this ECG? 1, anterior. 2, posterior. 3, inferior. Or 4, lateral. Great. All right, so a good mix here. And so the correct answer choice here is inferior. And so this what this question deals with, obviously, as you can tell, is that the challenge in detecting ischemia in someone who has abnormal depolarization of the left ventricle, and in this case, left bundle branch block. So what we're going to talk a little bit about are primary STT changes and secondary STT changes. So in uncomplicated bundle branch blocks, patients should have what's called secondary T wave changes, meaning that the STT waves should be in the opposite direction of the major vector of the QRS. So this patient here, the concern here is that they have these inverted T wave inversions inferiorly, right? So you have a patient who has a negative QRS complex in the inferior leads, but then also has T wave inversions that go in that same direction. And that's not what you should see. You should see the opposite. And for example, here in the anterior leads, where you have the QRS vector going negative and the T waves that are going positive, that's what we would see in an uncomplicated left bundle branch block. So as examples, here is a situation in which we have an uncomplicated or normal left bundle branch block. And here you see that in this case, in the inferior leads, the QRS vector is positive and the T wave vector is negative. But if you go back to our case, you have a situation in which they're concordant, and that's abnormal in the setting, particularly in lead 3 and lead AVF, where you see that the QRS vector and the T wave vector go in the same direction. So the take-home point here is that STT waves are typically in the opposite direction to the major vector of the QRS in uncomplicated bundle branch blocks. Case 5, an 80-year-old female with a history of a pacemaker placement due to sick sinus syndrome and Mobitz type 2 second-degree heart block presents with dizziness, lightheadedness, and nausea, approximately 90 minutes in duration. An ECG is obtained. What is the most likely cause of her symptoms? 1, a myocardial infarction. 2, atrial lead malfunction. 3, ventricular lead malfunction. Or 4, pericardial effusion. Okay, a good spread here. So the correct answer here is 1, myocardial infarction. In the previous case, we talked about someone with an intrinsic left bundle branch block. And in this case, we have an iatrogenic left bundle branch block because the patient's paced. And there are challenges, of course, with detecting ischemia when someone has a left bundle branch block. But what I want to point out here is that the marked elevation in the J point in the inferior leads, and you notice a little bit in lead 2, but pretty dramatically in lead 3 and lead AVF. So we're going to talk about some of the Scarboza criteria, and there are many of them. But the key point is that although ventricular paced rhythm is usually not interpretable for ischemia, there are certain criteria when present that are able to discern ischemia. And the key one in this case is that when you have ST segment elevation of 5 millimeters or more, that is discordant with the QRS complex, and that's number 3, which we'll go to. However, there are other criteria, and then these are the 3 criteria with the most independent value in the diagnosis of acute MI in the presence of a left bundle branch block, either intrinsically or paced. The first is ST segment elevation of 1 millimeter or more that is in the same direction or concordant as the QRS complex. As we talked about, concordance is unusual in a normal, uncomplicated left bundle branch block. 2, ST segment depression of 1 millimeter or more in any lead from V1 through V3, because they should be upright or elevated in those and uncomplicated. And 3, when you have dramatic ST elevation that's discordant, as seen in this case. So we'll show this case again. And what you see here is this dramatic 5 millimeter discordance in the inferior leads. Case 6, This ECG is most consistent with which of the following clinical scenarios? One, a 54-year-old man with a history of diabetes and crushing central chest pressure, acute in onset. Two, a 72-year-old woman with a history of hypertension and dyslipidemia with acute onset epigastric pain and diaphoresis. Three, a 32-year-old man with morbid obesity and asymmetric leg swelling and shortness of breath 2 days after abdominal surgery. Or four, a 44-year-old woman with a history of hypertension with positional pleuritic chest discomfort. Okay, wonderful. Everyone got this one. The correct answer choice here is four. A 44-year-old woman with hypertension and positional pleuritic chest discomfort. So this ECG is classic for acute pericarditis, right? So you have diffuse ST elevations that don't really obey a coronary territory, right? You see them laterally, you see them inferiorly, you see them anteriorly. And then there's some other subtle changes here that are notable. And one is that the other thing we look for is PR segment depletion, PR segment displacement. And what we can often see are when you see ST elevations or PR depressions. But I like to use AVR as what I call a summative lead. So it's helpful in ischemia, but it's also helpful in pericarditis. And what you see in AVR is that although you see ST elevations everywhere else, you see ST depressions in AVR. And I find that the PR elevation in AVR is often easier to see and notice than the PR depressions that you see in the other leads. But the take home point here is that diffuse ST elevations in the right clinical context is often consistent with acute pericarditis. But there is a differential diagnosis for this. And of course, we talked about left bundle branch block as one in the previous two cases. Early repolarization, we can be seen in normal variant, particularly in young people and in athletes. And of course, you have to think about ischemic heart disease as 1, 2, and 3 in the differential. Case 7, a 58-year-old female with a history of hypertension presents to her PCP's office for perioperative risk assessment before a total knee replacement. She has no cardiovascular symptoms. An ECG is obtained. Which of the following was the most likely cause of this patient's abnormal ECG? 1, prior MI. 2, current ischemia. 3, hypertrophic cardiomyopathy. Or 4, prior myocarditis. Great. So a good spread here, but the majority got this, and that's choice 3, hypertrophic cardiomyopathy. So what does this ECG show? Well, there's sinus rhythm and there's evidence of left ventricular hypertrophy. And the most notable findings when it comes to the ST segments and T waves are these pretty deep T wave inversions in V3 through V6. And we often see this pattern in patients in particular with hypertrophic cardiomyopathy, but in particular the apical variant, also known as Yamaguchi syndrome. And so here's a case report from the Heart Rhythm Journal of a patient with MRI images below and the ECG above, where you see this spade-like pattern in the hypertrophy that you almost have complete apical cavity obliteration during systole. And then when you look at the delayed enhancement images, many of these patients will have late gadolinium enhancement in that apical area. So there are many flavors of hypertrophic cardiomyopathy, including what the ventricle looks like in terms of the pattern of the hypertrophy, as well as the prevalence and in the ages, as well as the probability of having a sarcomeric variant or positive genetic testing. And apical HCM often is not associated with abnormal genetic testing, but something that needs to be on the mind when you see that an ECG like this. And I can assure you all, you've either all seen this ECG already or will see this ECG. Case 8. A 39-year-old male presents to the emergency department with 2 weeks of intermittent chest discomfort while jogging. An ECG is obtained. Troponin T was elevated at 0.07. Due to concern for a non-ST elevation MI, he underwent a coronary angiogram, which revealed no obstructive epicardial disease. Which of the following was the most likely cause of the ECG abnormalities? 1. Myocarditis. 2. Pulmonary embolism. 3. Pericarditis. Or 4. LVH with associated strain pattern. So this is the patient's current ECG, and I actually have the patient's prior ECG here. So this is from an ECG a few years prior as comparison, and I'm going to put up the current ECG again. Great. So a good spread of answers again, which is great to see, but the majority did get this, and that's myocarditis. So a couple things. One, clinically, the patient's presenting with chest pain. There is an abnormal ECG here, right? So you have T-wave inversions that are new when compared to the prior ECG we have on file in V5 and V6, but the patient has no epicardial coronary disease on an angiogram. And of course, a patient with symptoms, elevated biomarkers, and an abnormal ECG, you need to rule out epicardial CAD. And so we're going to get into this a little bit, but what is the differential diagnosis for patients who have chest pain, abnormal ECG, and elevated troponin? And my top three, in the absence of coronary disease, are myocarditis, stress cardiomyopathy, or pulmonary embolism. This patient indeed had an MRI done later in the stay and actually showed distal, inferior, and anterior wall hypokinesis and leg galen enhancement consistent with myocarditis. There's also evidence of edema by T2 weighted imaging. And so pointing out here. And here's that summary slide I was referring to. So there are many causes, as you all know, quite acutely, of myocardial injury in the setting of no epicardial CAD. And they're common. Particularly on the hospital medicine service, the indeterminate or multifactorial causes are very common. And so this is a slide from the European Heart Journal from several years ago that I like to reference during inpatient rounds that really has a nice differential diagnosis of this entity. Case 9. A 61-year-old male presents to urgent care clinic due to non-exertional sharp chest pain over the last 2 to 3 months. An ECG is obtained. Evidence of which of the following is present on his ECG? 1. Right bundle branch block. 2. Right ventricular hypertrophy. 3. Right ventricular strain. Or 4. Brugada pattern. Great. Okay, so the correct answer choice here is 4, Brugada pattern. So what are the notable findings on this tracing? So in V1, V2, and V3, but in particular V1 and V2, you have these ST elevations that have this coved appearance. And in V1 and V2, they're associated with these T-wave inversions as well. So why is this important to detect? Well, of course, the Brugada pattern can be associated with an increased risk of ventricular tachyarrhythmias and even sudden cardiac death, which is known as the Brugada syndrome. Now, the answer choices included kind of right ventricular things because similar ECG findings can occur in RV ischemia or hyperkalemia. So pointing out this here. And here is a few tracings from patients with either type 2 or type 1 Brugada. You'll see that the type 1 is what we saw in the prior tracings, and type 2, you have a little bit more of this saddle-like appearance. But again, it's in V1 and V2 that you see the abnormalities. And so these are patients that underwent actually intravenous administration of procainamide. And for this patient, you're able to kind of bring about that Brugada ECG. And then with quinidine therapy, you see that the elevation is attenuated. So what are the important parts of Brugada syndrome that you all should know? So it's associated with a high risk of sudden cardiac death. The causative mutations are in the SCN genes, SCN5A and SCN10A. But cases of suspected Brugada syndrome, so if you see an ECG abnormality that looks like Brugada, you should, one, query about a question of palpitations or syncope, and all these patients should be evaluated for an underlying heart disease by a cardiologist as well as imaging. So that's the reason why it's a can't miss ECG. Case 10, an 80-year-old man presents to the emergency room due to recurrent episodes of dizziness and lightheadedness not associated with activity. Examination is notable for bradycardia. An ECG is obtained. Which of the following is present? 1, first-degree AV block. 2, Mobitz type 1, second-degree AV block. Or 3, Mobitz type 2, second-degree AV block. Or 4, third-degree AV block. Great. Okay. So majority got this, and this is Mobitz type 2, second-degree AV block. So 2-to-1 AV block can be tricky, right? And of course, with 2-to-1 AV block, you want to differentiate between something that's nodal, Wenckebach or type 1, which in general is benign, or infranodal disease, which is Hisian disease, which is abnormal, and that's Mobitz type 2. And the reason why this is important is that symptomatic type 2 AV block is an indication for a pacemaker. So differentiating, as I said, when you have 2-to-1 block between Mobitz type 1 and Mobitz type 2 can be tricky. But there's a couple of things here that support Mobitz type 2. One is that this patient has conduction disease, right? This patient has a right bundle branch block and also has first-degree AV block at baseline. So when you see that, as well as the fact that the patient has left axis deviation, indicating left anterior vesicular block. So in someone who already has conduction disease, who then also has suspicion for abnormal AV conduction, your index of suspicion for infranodal disease is also already higher. Now, there are a couple other features here that I want to point out that's kind of 2.0 type etiology here. And that is when you have a dropped P wave, as indicated by the black arrow, when you have Mobitz type 2 block, there usually is not a change between the PR interval in the beat before and the beat after. But when you have Wenckebach, which is Mobitz type 1 block, you usually have a slightly prolonged PR segment before the dropped P wave, and then it returns back to the baseline. So when you see this variable PR segment, that hints at having Mobitz type 1 block. So the PR intervals before and after the non-conductive P wave are about the same in Mobitz type 2 secondary AV block, and Mobitz type 2 is an indication for pacemaker placement if no reversible causes are identified. And again, this because it identifies infranodal Hisian disease. Case 11, a 33-year-old female with lupus presents to her rheumatologist's office with an increased shortness of breath over the last 2 weeks. The examination is notable for tachycardia. An ECG is obtained. What is the likely etiology of the patient's shortness of breath based on the ECG? 1, pulmonary embolism. 2, ILD. 3, a pericardial effusion. Or 4, ischemic heart disease. So this is the patient's current tracing. I'm going to show you an ECG at baseline for her. And I'm going to show you the current tracing again. Great. Okay, so majority got this, and then the correct answer choice is three, a pericardial effusion. So there are a few features of this ECG that are of note, right? So one, the most striking one is the low voltage, right? And so what do we define as low voltage? The way I remember it is I put my hands over the 12 lead ECG, and I say that if you have a QRS amplitude of less than 5 in the limb leads and less than 10 in the precordial leads, that is indicative of low voltage. And so what are the causes of low voltage? So in this case, this patient had a pericardial effusion. But the way I think about low voltage is that if there are non-electrical conduction things between the ECG leads and the patient's electrical system or the myocardium. So often we think about fluid, but in patients with significant pulmonary disease and obstructive lung disease have a lot of air between the ECG leads and the myocardium. And the other thing I think about is that is there something in the heart that's not muscle, right? So if you have, for example, cardiac amyloidosis, when you have infiltrative cardiomyopathy, although you have increased LV wall thickness, you have less muscle, and therefore you have low voltage. Other causes are listed there. The other thing that's notable between this ECG is we have electrical alternans, and that is that you have slight changes in the amplitude you see in the rhythm strips of the QRS complexes. And so electrical alternans is, by definition, the amplitude changes from beat to beat. And a common cause is pericardial effusion, as in this patient, but there are other causes, including both supraventricular and ventricular tachycardias. And then in our service and cardiology service, patients with advanced heart disease can have this. And they just have it's basically a myopathic process in patients with end stage cardiomyopathy. So case 12, a 32-year-old man with a history of schizophrenia and current tobacco use presents to an urgent care clinic due to palpitations. An ECG is obtained. The patient is at risk for developing which of the following? 1, atrial fibrillation, 2, torsade, 3, ventricular tachycardia, or 4, AV block. Great. So majority of folks got this. So the correct answer choice here is torsade. And so the tip off here, of course, was the history of schizophrenia with treatment with QTC prolonging medicine. So what I want to go through is kind of what are practical recommendations for QTC, right? So this is a common occurrence on the hospital medicine service, which are patients who might have a prolonged QTC. You're thinking about an antibiotic or an antipsychotic or other medicines, and who's really at risk for developing torsade. So one, let's go through how do we calculate a QTC. Bazette is the most common method, and it's the one that I use. And what it really gets into is the following. One, you measure the QT interval. And then 2, you use the heart rate to determine the RR interval. And then you take the way you get the QTC is that you take the QT and you divide by the square root of the RR interval in milliseconds. And so this patient had a QTC of 536 milliseconds. Now, you have to search the data pretty deeply to find out what's kind of normal. And it turns out for normal people, the average QTC is around 440 milliseconds. What are some of the QTC prolonging medicines? You all know these quite well, but these are the ones I think about, in particular, antiarrhythmics, antipsychotics, antibiotics, and of course, antiemetics. But what are who are the patients you really worry about? And so I think this AHA-ACC statement is quite helpful for inpatient medicine. And that is, one, you need to have prolongation of the QTC from baseline of 60 milliseconds. And two, the resultant QTC should be over 500 milliseconds. So if I see someone who has QTC prolongation with therapy, but their QTC after therapy is still below 500, I'm less worried about those folks. The people I worry about are the patients who have a QTC, a new QTC that's above 500, and that's a delta of 60 from the baseline. Case 13, a 76-year-old man with COPD is admitted to the medical ICU with urosepsis. What arrhythmia is present? One, atrial fibrillation. Two, AVNRT. Three, multifocal atrial tachycardia. Or four, sinus tachycardia with sinus arrhythmia. Great. So good mix of answers here, but most people got the correct answer, which is MAT. So why is it multifocal atrial tachycardia? Couple of reasons. One, it's not atrial fibrillation because you do see some organized atrial activity. You do see P waves, right? But there are at least three different P wave morphologies. And that is classic for either a wandering atrial pacemaker or multifocal atrial tachycardia. And the only difference is the heart rate. So if the heart rate is 100 or greater, we say MAT, or the heart rate's less than 100, we say a wandering atrial pacemaker. So MAT is an SVT resulting in rapid irregular atrial rhythm, usually caused by multiple ectopic foci within the atria. As we discussed, the heart rate is greater than 100 beats per minute. And the most common location I see this is in the thoracic ICU. So elderly patients with underlying chronic conditions such as COPD. And again, it's called a wandering atrial pacemaker if it's less than 100 beats per minute. Okay, so case 14. A 42-year-old man is admitted to the general medicine service with cellulitis. An ECG is obtained due to a slow heart rate. What is the rhythm? One, ectopic atrial rhythm. Two, sinus rhythm. Three, atrial fibrillation. Or four, junctional rhythm. Okay, so most folks are kind of between an ectopic atrial rhythm and junctional rhythm. And so the correct answer here is an ectopic atrial rhythm. So why is that the correct answer? So one, there is an atrial rhythm here, right? So if you look at the rhythm strips, you see organized atrial activity, and they're the same morphology, unlike the previous case. But what's unusual about this is that they don't behave normal sinus P wave morphology. And what I often tell folks are sinus P waves are upright in 2-3 AVF, V4 through V6. And what you see here in this patient most clearly is that in 2 and AVF, you see that the P waves are negative, and you also see negative P waves in V4, V5, and V6. When I see negative P waves, the first thing I look for to see if the QRS complexes are negative in 1 in AVL. The most common cause of negative P waves in 1 in AVL and a negative QRS complex is limb lead reversal. But you don't see that here. They're upright in 1 in AVL. The QRS complexes are. So this is someone who has an ectopic atrial focus and ectopic atrial rhythm. And really, this is of no real clinical concern. And finally, case 15, a 31-year-old woman is admitted to the general medicine service due to recurrent syncope. What is the most important finding on this ECG? One, normal sinus rhythm. Two, LVH. Three, Mobitz type 2, second degree AV block. Or four, pre-excitation. Great. So respondents were between LVH and pre-excitation, with the majority getting pre-excitation, which is correct. And so the classic WPW triad are a short PR interval, 60 milliseconds, delta waves, and a wide QRS duration. And what are delta waves? The key feature here is that you get slurring of the beginning of the QRS complex. And the reason for that is that you get depolarization not only through the AV node, but also through a bypass tract. And therefore, you have what's called early depolarization. And so you have slurring then of that QRS complex, which you don't usually see. You usually see a rapid uptake when conduction is through the AV node. Now, an EP study for this patient confirmed a right anteroseptal bypass tract. Anteroseptal bypass tracts are actually uncommon, including only about 5% of cases of WPW. This is a more common pattern in WPW, and these patients have what we call kind of a pseudo-inferior MI pattern. So you still see this delta wave, but you see these negative QRS complexes in leads 2, 3, and AVF. And so these are indicative of a posterior septal bypass tract. And so the classic WPW triad, as referred to, is 1, short PR interval, 2, delta waves, and 3, a wide QRS duration. And with that, I want to thank ECG WaveMaven from the BI for some of these tracings, and then my clinical mentors who taught me a lot about ECGs, Dr. Dale Adler and Dr. Len Lilly. Thanks very much for your attention.
Great. Thanks so much, Sanjay. This has been a great talk, great overview. Just wanted to get to a couple questions here if we have time. There was a couple great questions from the audience here. So the upvoted one: how do you differentiate early repolarization from ischemia?
Yeah, great. So when I think about early repolarization, it has kind of a diffuse type pattern, almost like a pericarditis type pattern. We often see it throughout the anterior precordial leads. And again, in someone who doesn't have symptoms, right, it'd be hard to invoke diffuse anterior ischemia. So part of it's clinical context and part of it is the pattern. But oftentimes early repolarization is throughout V1 through V6.
Excellent. Okay. So please comment on measuring the QT interval in patients with bundle branch block.
Yeah, great. So this often comes up, and I'm glad this question was raised. So if you look at the literature, there's not clear directions on this, but in my study of this, what I use clinically is that I take the QRS duration above a QRS duration of 120, and I add that to the QT. All right. So what it gets to is, I subtract that from the QT, right? Because the idea being, if your QRS is prolonged X amount above normal, that's part of the QRS as opposed to the QT. So if it's 140, I use a delta of 20 milliseconds in that sense to adjust what the QTC is.
Great. How reliable is the calculated QTC on the EKG?
Yeah, in general, pretty good unless there's irregularity. So I have to be honest, if I have sinus rhythm, it's pretty good. Atrial fibrillation, it really goes awry. And in cases where the RR interval is irregular, I use the longest QT that I can find.
Awesome. If you see anteroseptal ST depression, should you always get a 15 lead?
Yeah, so anteroseptal depression, I guess you get should we get a posterior tracings? Yeah, so I would say it can't hurt. More data, the better in this scenario. The most common causes of anterior ST depressions are still going to be a non-ST elevation in MI anteriorly. But if you see inferior changes and you're concerned, I think it would be very good to get a posterior tracing.
Great. So how about axis deviations with bundle branch block?
Yeah, so in general, one of the most common causes of left axis deviation is left bundle branch block. And we sometimes see that in right bundle branch block, the opposite. I don't make too much about axis deviations, to be honest. The one time that I think it's very helpful is if you see 2-to-1 AV block, and then you see left axis deviation. because that suggests that someone has left anterior fascicular block and therefore likely has some His-Purkinje disease. So if I see left axis deviation in someone with 2-to-1 AV block, I'm much more suspicious of there being presence of type 2 second degree AV block.
Okay. Do we need to worry about QT prolonging meds in patients who are permanently paced?
Yeah, so the answer to that is yes, you still do need to worry about that. There is a less of a worry because a lot of the QT prolonging is from the QRS. So as long as you adjust for that, you should be okay. But even after adjustment, if you do see QTC prolongation, there is a concern still of having an abnormal QTC.
Junctional rhythm also has a negative P wave, right? How to differentiate from ectopic atrial?
Yeah, great. So sometimes you can get a negative P wave in junctional rhythm. However, oftentimes it's after the QRS complex because you get a junctional origin to the rhythm, and then you get retrograde conduction. And so what you'll see is a QRS complex without a preceding P wave, and then a negative P wave after the QRS complex.
Question about case 8. What was the echo findings where you got an MRI for the myocarditis?
Yeah, good question. So there were no wall motion abnormalities on the echo. And so we went to MRI because our clinical concern was there for myocarditis. And it's a good point in general for unless you have fulminant myocarditis or sarcoidosis that involves heart failure, the sensitivity of echo alone in making the diagnosis is pretty low. Specificity high, sensitivity low.
Could you elaborate on using AVR as the summative lead?
Yeah, great. So, so I'm in the stress lab as I mentioned today, and so when I see someone with, sometimes we'll get called about AVR elevations, and people get nervous. What I think about AVR as is if I see someone, if there's symptoms or ischemia, what we often see are diffuse SC depressions, which are indicative of subendocardial ischemia. In those settings, we almost always see AVR elevation. That's not an ST elevation MI, right? What that is AVR being a summative lead showing that the rest of the leads have diffuse subendocardial ischemia and ST depressions. The most helpful clinical scenario to use AVR, in my opinion, is as described in the case, which is an acute pericarditis. So if you see kind of, Chris, one of the earlier questions was about early repol, right? So if you see diffuse ST elevations and you see ST depression in AVR, that to me is much more indicative of pericarditis.
Right. Good. I think we have time for one more. Can you explain the Brugada coved ST elevations?
Yeah. I don't know if I can explain them, but I can say that, what the pattern looks like. So it's kind of that in type 2, you have that kind of triangular type shape, and that's the case we showed. And then type 1, you have a little bit more of this saddle etiology. Now, what's the reason for it? This is a sodium channel problem. And so the thought is that it could be related to the depolarization, repolarization. But that's a pattern recognition type ECG for sure.
Great. Well, thank you so much, Sanjay. Really appreciate you being here, and hope you have you back next year.
Thanks, Chris. Look forward to it. And thanks again for the invitation.